Associate Professor MKCG.
Sorry for interruption. I want all participants of Hall Tiratgarh to move to Hall Tiratgarh because we are restarting our rest of the lectures.
Associate Professor MKCG Behrampur, Dr. Abhay Patnaik, Senior Consultant Cuttack, Odisha. And our expert is Dr. Amol Patgaonkar, Dr. Pushpavati, Dr. Suman Mittal, and panelists are Dr. Asha Jain ma'am, Dr. Shashmita Swan, Dr. Reema Dilavari, Dr. Geeta Agrawal, Dr. Shushma Purohit, Dr. Sanchita Pal, Dr. Ankita Goel, Dr. Neha Jaiswal, Dr. Shushila Kunte, Dr. Suman Mittal, Dr. Supriya Gupta, and Dr. Sarita Rajbhar.
The scientific program in the second hall, Tiratgarh Hall, is also on. So the people attached with that program, please, they can move there.
Hello, good afternoon to everyone. I request all the panelists to introduce themselves. I request the panelists to introduce themselves.
Hello, good afternoon all. I am Dr. Geeta Agrawal, Consultant Heritage Hospital.
Krishna. Madam is Krishna.
I am Dr. Geeta.
Geeta. Next.
Hello, I am Dr. Sanjita Pal, currently working at 50-bedded urban CSC.
I'm Dr. Reema Dilavari, consultant at Gyan Devi Clinic.
Morning all, I am Dr. Sushila Khute, Deputy CMO from Western Coalfield Limited. Hello all, my name is Dr. Sushila Khute. I am Deputy CMO from Western Coalfield Limited, Nagpur area.
I'm Dr. Asha Jain.
I welcome all the learned panelists and the experts to this panel on the research and cancer, and the subject is cancer prevention, early detection, and survivorship in midlife women.
Hello. I thank the organisms they have chosen 4 important case scenarios, and I am going for the first case. This is a 48-year-old woman who recently attended a funeral ceremony of her neighbor, aged around 42 years, who died of prolonged treatment for breast cancer. Out of fear, she rushed to her clinic and asked for a complete cancer checkup. With this background scenario, I want to know from my esteemed panelists that what is the prevalence of different cancers in India in women? What cancer a gynecologist like us can screen for the woman? How to proceed to screen this woman? And what are the screening tests available in India? And how to screen her? As you know, this screening is the presumptive identification of unrecognized disease by the application of diagnostic procedure which can be applied rapidly and safely. So, when there is a screening program in there, we want 4 things from the panelist. One is as it is screening for the cancer, we wanted relevant personal history. Second is relevant family history, relevant baseline health evaluation. Then you plan for a risk stratification, whether the woman belongs to a average risk, low risk, or a high risk, and accordingly you can plan for a breast cancer screening. So, Madam, can you start with what is the prevalence of cancer in women in India?
most common cancer is breast cancer, and it accounts for 30% of 25 to 30% of the cancers. The cervical cancer accounts for 15 to 20%. Then comes the ovarian cancer, which accounts for 6%, and the other cancers, which are the GI cancers and all, they they are up to the tune of 30%.
Thank you, madam. Around, as a gynecologist, we can screen these 4 cancer. Though the incidence of the cancer in India is less comparison to the high middle income country, but the death due to cancer in India is more than the prevalence it has in comparison to high income society. So we'll go for the cancer. Breast cancer is a most common cancer that is we found in India. How to proceed for breast cancer screening in this woman? What are the screening tools available and how we are going to screen her? Yes, madam.
Ma'am, first of all, personal history should be taken, and patient's family history should be taken, and after that, ma'am, clinical examination should be done, per abdomen, PS, PV, and
Breast examination. We are doing breast cancer. Oh, yes. So actually, whenever you are taking for the personal history and family history to know the for cancer screening, you should have something background in your mind. What are the risk factors? So how we are going to take the personal history and family history in a case of when you are going to screen a woman? What are the things you want to ask?
For personal and family history is important here. Family history is important here. We should ask for the family history, whether any first degree or immediate relative.
Pedigree analysis.
Yeah.
Maternal side or paternal side,
or paternal side will both.
two generation pedigree analysis should be done, and these things are the risk factor. Whenever you have something in your mind, then you can get anything early menarche, early late menopause, nulliparity, whether she has breast for her child or not, and what is her ethnicity she belongs to, what is her BMI, any history of alcohol, smoking, and any mammography suggestive of dense breast mass, then are all risk category. So there are so many models available to assess this, stratify whether the cancer, the woman is at what risk. Naturally, we are using the Gale method for Gale model for analysis because it's very simple. And but most oncology department, they are using the Thyroid model. And after you take all the 13 parameters that has been discussed, and that you put it in the model, in the AI model, you can put it the history, then it will give you a scoring system. If the scoring is less than 15% in the Gale model or less than 17% in the Thyroid method, then she is a low risk. So what are the screening methods available for the women for breast cancer?
Mammography.
First is the clinical breast examination.
Breast examination, first of all, examination.
MRI.
MRI in high risk.
Yes, but these are the available sometimes histopathology. So this woman, this 45-year woman, she had one maternal aunt, she has had breast cancer, and you put the risk factors in the Gale model, and it came out to be 21. How you are going to screen this woman?
I started at the age of 30.
No, she belongs to intermediate risk. If it is between the 17 to 30%, she is between the intermediate risks. So accordingly, you have to study. We are discussing case-based discussion. So according to her risk, we'll screen her.
She came under intermediate risk. So mammogram should be every 1 to 2 years, starting from 40 years of age. If breast density came more than 75%, then annual mammogram should be done. And annual ultrasound should be complemented, and annually clinical breast examination by clinician should be done.
So the summary is that if she belongs to a average risk or low risk, then clinical annual breast examination and also mammogram every year starting from the 40 years. So breast awareness, regular self-breast examination once a month, a few days after menstruation is over, that patient should be aware of. Next, how to screen for cancer, sir will moderate it.
So, another common cancer in the female is the cancer cervix. And I want some comments on the previous slide on the breast cancer screening.
See, I just want to say, even if we categorize the patient as low risk, intermediate, or high risk, the method of screening doesn't change. So, whenever we see, like when we are going to do MRI, so it is rarely done when we are going to do it when we know that the patient is gene positive, their history of breast cancer, and if she is BRCA1 positive, only then we are going to do the MRI. Otherwise, the protocol for screening is go for clinical breast examination and mammography. And along with mammography, always sonography is done. Now, problem with mammography is even if the patient falls into high risk, if you do a mammography in 30 years female, you are not going to find anything because the breast is dense. So now it's a very debatable thing if when to get mammography start in a female, whether we should do it in a 35 years, 40 years or 45 years. So the higher the age, the better the mammography gives something about the early lesion. So even if we classify patient as low risk, intermediate, high risk, the screening protocol doesn't change according to age, even if the patient falls into whatever risk. So the question is how many times we are going to do a BRCA positive gene, or how we are going to find a BRCA positive patient who falls into higher risk.
Sir, there is another case scenario regarding high breast risk cancer. So we'll discuss it next.
Coming to the screening for cervical cancer, I would like to ask you whether the cancers are preventable or not. Is it preventable?
Cervical cancer is the only preventable cancer which we can prevent by promoting the HPV vaccination. And as a gynecologist, it's really an opportunity as we are the shield for the patient. Whenever the patient come to us in our OPD, we can prevent that by promoting the HPV vaccination to all the girls. As per the WHO guideline, there is also target of 2030 have 90% vaccination for girls below 15 years and 70% patients should be screened for cervical cancer and 90% patients should get treated if they are diagnosed with cancer at the early.
And if only not only the vaccination, we can divide the prevention modes into primary, secondary, and tertiary prevention. Primary prevention is always you have to work hard, but the exercises, yoga, nutritious diet, put your healthy weight and healthy body style, reduce tobacco smoking, reduce alcohol. These are also the primary mode of prevention of the any of the cancers. And secondary is the early detection and screening and early detection, and so that you can detect early and treat early, so that she will not go into the actual cancer. That is the mode in the secondary mode. And tertiary mode is when you get a case of cancer cervix and you have to treat it, and so that she is out of the danger, out of the disease, and she can be treated in such a way that can have a good quality of life further. So that is our aim in the tertiary mode of prevention. So let us have to how to screen. All you know that this is the WHO SDG guideline 2030. That is means 90, 70 and 90. That is 90% girls to be vaccinated by age 15 and 70% women with the HPV screened by 35 or 45 and 90% of cervical disease treated. But we are far away from the target because we are already in the 26 and another 4 years more. So do you expect that we can achieve this?
This is not achievable for us at the present moment.
Yeah.
But if we start building towards it, we'll reach it. थोड़ा देर से सही, but we will reach it. But right now, with the government pitching in, it is time for everyone to be sensitized.
Yeah.
And start talking about it, create awareness. Because see, our country is such a country that we had the whole country vaccinated twice for COVID. 3 times within a year. So if they want to do it, they can do it. But you have to see that a lot of anti-vaxxers are coming up, that their voice is submerged. We are able to actually convince the people to take the vaccine. It is unfortunate and fortunate in our country that anything that is free has a good uptake. So if the government is giving it for free, people will take it without questions. So that is one positive aspect we have. But if you say whether we will obtain the entire SDG, it is not possible because it is 90-70-90. 70% screening of eligible women is nowhere on the horizon. And then treatment of 90% of the eligible screen positives. So if you're not screening, then the next question doesn't come itself. Because at present in our country, the percentage of screening is less than 5%. That is the current state.
So very good message she has given to the audience that sensitization is most important. We have not achieved yet this thing, but the goal is very fixed goal in the 2030. But one important message she has given, that sensitization to the doctors who are screening, and they should screen all the patients as per the protocol or guidelines. And important thing is that the service receiver, that is the clients, the patients also should be sensitized, and she should know the basic things of the screening, how this can prevent the further cancer growth.
If a new biscuit or a new toffee or a new drink comes up, a fizzy drink which is nothing but sugar and flavored and which is so bad for your health.
Yeah.
They advertise the hell on the world everywhere, and people think एक बार try तो करते हैं. So ultimately that advertising strategy will have to come up. You remember when the eye pill came, it was advertised left and right on social media and on television. Today the government wants to stop it, can't stop the sale because the eye pill is still selling like hotcakes. So without advertisement, I don't think we will be able to achieve anything.
Yes.
We cannot skimp on advertisement and hope to get results.
Thank you, madam, for your points. And important thing is that now the government has given free immunization vaccines to 9 to 14 years girls, and that is as per WHO protocol. And before we start the screening, so whom to be screened? Whether whom to be screened? Yes, madam. Whom to be screened?
So, in the, where the population is of average risk.
All population will screen, or age factor is there, those who can screen them.
No,
As
in
per
average-
SCOG guidelines, as per
in-
WHO
You
guidelines.
would screen 30-year plus.
Yeah.
30-year plus, you would have to screen. Depending on the mode of screening, either you can have an HPV LBC, which has to be a standardized test when it will be once in 5 years. But other modes, it has to be once in 3 years, though the guidelines, WHO ultimately says that if you can have 2 screenings at 35 and 45, that will also reduce by 50%. But that is not ideal. Ideal is to have an HPV LBC once every 5 years, 30 years onwards. If she is HIV positive, it is 5 years earlier.
Yes, thank you. And as per the guidelines of the WHO, what madam said, that you should screen from the age of 30 years to 65 years. Every 5 years, you have to screen. And mode of screening. What are the mode of screening? What is the method which you have to do? And but the SCOG guidelines, American Society, they tell that the screening should be much earlier, that is 21 years. From 21 to 29 years, you screen every 3 years pap smear.
Sir,
And from
ideally, once sexual activity begins,
Yes.
you should start after 5 years. Simple. But you will get so much of HPV positive, aap pagal ho jao. So
So
for
cytology-
HPV, you have that cutoff
30.
of 30 years. And
As
for
per the WHO
LBC,
guidelines-
you can continue 21
yes.
onwards.
We are going by the WHO guidelines that from 30 years onwards up to 65 years, we will screen all the women and with in the 5 years interval with HPV DNA testing. That is the basic testing now by WHO recommendation, and you will do that. Or if you are not able to do the HPV testing, you have to do pap smear every 3 years, and or co-test, or you can do pap smear, or if possible with the DNA HPV testing, which can be done. But in the low research setting, where such facilities are not available, as proposed by the non-NCD program of the Government of India, we are doing VIA. VIA is a simple method, that is visual inspection with acetic acid.
Doesn't work, sir. It doesn't work.
Doesn't work, I know. But we are, because of the mass screening, long population.
Because it is a mass. The patient who dies is not a mass. She is not a statistic.
So,
She is a person. And so I would not agree to this.
this is not agreed. This is not agreed internationally, but it is as per the guideline, where the low research setting, where facility for other facility is not there, where pathology is not there.
But
What you can do?
has also said that if you have no screening facility, start HPV. Don't
that
waste
is-
time
that
and
is
money
good.
on anything
But-
else.
but
That
you
is
cannot-
what WHO recommendation is there.
But we cannot recommend HPV testing in the field because of the cost, unless the government gives it free of cost.
Sir,
So
अभी
screening will be
तो बहुत
difficult.
सस्ता हो गया,
So
800
that is-
रुपए में हो रहा है.
Therefore, it is very important that primary testing should be HPV DNA screening, because previously we are doing it pap smear, but pap smear is now become replaced by the HPV DNA testing in the 30 to 65 years. So, as per the recommendation, if more than 65 years, you may stop the screening, because if there is no positivity during these years from 30 to 65, you can change over, you can stop this after 65 years, unless there is some symptoms. Or on high risk mothers, you can continue, where there is high risk mothers like immunocompromised HIV patients, previously CIN 1, 2, 3, those cases you have to screen for a long time, even after 65 years. So what is the screening methods that we have discussed? What is the vaccination protocol for this protocol available with us? What is the WHO protocol for vaccination?
So 9 to 14 years is 2 doses of vaccination, and we can catch up them up till 26 years for 3 doses. We can vaccinate the women up to 45 years with 3 doses. But now they are saying 1 dose can also suffice.
Yes.
In younger women.
So
and,
WHO
less than 20 years.
protocol says that it should be single dose into 9 to 14 years. Or you can give 2 doses up to 21 years if possible. And when you are giving 2 doses, it should be separated by 6 months,
6 months.
gap, so that this is covered. But what you have told, that catch-up vaccination can be done if they have not done vaccination in the 15 to 20 years. After 15 years, you can give catch-up if she has not taken within 14 years or 9 to 14 years. So that is catch-up vaccination, which can be given as 2 doses. So what is the advantage of HPV screening other than the pap smear? Why you are compelling that HPV screening is better than the pap smear? Previously, age long, because since lot of years we are going there for pap smear. Now we are coming to HPV DNA vaccine.
We have to be realistic in our conditions. With our population, one person is supposed to read not more than 100 slides a day. If you are really going to screen all your women, the number of pathologists required would be 100 times what we already have. That is one. Number 2 is the interperson variability of a pap smear is very high. That you will get a positivity ranging from 20% to sometimes 80%. But that sensitivity for screening is not good enough. For screening, a test with high sensitivity, though the specificity may be low. So for pap smear, it is good as a triage test later. You do an HPV. If it is positive, go ahead and do a pap smear or do
Yes,
a
yes.
core test
Yes.
because it is more specific, but it is less sensitive.
And also
Highly,
there's
it is highly
prognostic
sensitive.
value.
Highly sensitive. It can also, because in the pap smear, there is infection, there is blood, there is mucus, so you cannot do proper examination. So it also eliminates this because we are doing the cytology based screening here. So you are liquid based cytology you are doing with HPV DNA testing. So there is more sensitive. And coming to the vaccination, what are the types of vaccination?
Types of vaccination are there: bivalent, quadrivalent,
What
and
is
monovalent.
it? So important thing is, once the vaccinated, this doesn't eliminate screening. You have to continue screening. So once you get a positive result, that once you get a positive result, then you have to go for colposcopy or biopsy. So in biopsy and cytology, if you see in the histopathology, there are CIN1, CIN2, CIN3. That is intraepithelial cervical intraepithelial neoplasia. CIN1 is low grade and CIN2, 3 is high grade. So they should be followed up more repeatedly. And in cytology, you may have LSIL, HSIL or HSIL2. That is means high grade lesion, squamous epithelial lesion or low grade squamous.
Sir, even that has
Depending upon this.
biopsy has also become LCL and HCL only.
Yes,
Now
yes.
CIN 1, 2, 3 is gone.
Yes, yes,
It's
yes.
LCL and HCL.
So you are also pap smear, we are doing Bethesda's technique. So this ASCUS is another. Is ASCUS if you get, that is a
ASCUS H is the one where you have to go for colposcopy.
atypical squamous cells seen of
Undetermined-
unwanted significance.
undetermined
So that is ASCUS also can be there, but is of little significance. So key message is vaccination by 15 years and screening in the 30 to 35 years, and treatment should be colposcopy if you get positive, colposcopy and directed biopsy and treatment by loop excision is most important screening method. Thank you.
So after cancer screening, we had to screen her for ovarian cancer. Is there any protocol for screening, mass screening?
Chalo, chalo.
No.
Yes, there is no routine screening at present, not recommended by United States Preventive Task Force. But if there are so many markers, ovarian cancer causes more death than any other cancer of the female reproductive tracts. And there are so much biomarkers and screening methods and diagnostic techniques are available. And that is for high-risk mothers, high-risk patient. Routine screening is not currently recommended by any professional society, including FOXY. But when woman is at high risk, and know if there is a family history of ovarian cancer, breast colon cancer, or there is genetic mutation of BRCA mutation or postmenopausal women or increased risk, then you can have a screening method. So what is the protocol for screening for the ovarian cancer for in a non-risk patient and high-risk patient? If it is there is no risk factors is there, no risk,
such
no
protocol.
screening method is required. But if there is a, HOBC is there, hereditary ovarian breast cancer syndrome is there, it controls only 5 to 10% of women who are having a familial and hereditary. You know the difference between hereditary and familial. Hereditary means there is a definite genetic mutation is there. Familial means there is some, maybe the lifestyle, maybe the ethnicity that is also compounded. We do not know the genetic compound, but you should screen if there is a family member suffering from HOBC something. So if any family member is suffering from HOBC, how you are going to screen? That is the only thing in the ovarian cancer screening.
So there can be risk of malignant index score which can.
What are the current screening options available for the ovarian cancer? Two things. What are the current screening options available for endometriosis?
So
No, all the women's as a standard, there is no recommendation because it has not seen any benefit in terms of early treatment or better cure or survival. So for routine, it is not recommended, but for high risk women, particularly who have hereditary syndrome, like example, if somebody has BRCA or Lynch syndrome or any other hereditary syndrome, in those cases, we recommend doing standard
Transvaginal
procedure.
ultrasound, CA125.
CA125 and at times even transvaginal sonography is also.
These are the only recommended screening methods for ovarian cancer screening. Those who are only can be who are HOBC positive. There are so many epithelial cancer and that are having the genetic inheritance. There are autosomal dominant variety of transmission. And if you do a genetic testing that can end uncertainty and clarify the cancer risk for other individuals in the family and clarify the cancer risk for the relatives, and you screen the person who is suffering from the breast or ovarian cancer, then go to the relatives who are related so that you can screen. Suppose you are screening them. So if suppose somebody is positive for the BRCA mutation, what treatment you are going to offer them? Is it helpful? Whether the genetic testing for a HOBC woman who is suffering from ovarian cancer to the relatives, is it beneficial to the relatives or not? We are not routinely doing, but it is beneficial.
We should screen them for the breast cancer and the ovarian cancer and that patient, high risk patient. Yes, it's beneficial.
So is it beneficial? If you know that the family members are suffering from BRCA, then they are at risk of having ovarian or breast cancer 10 years earlier than what their relative is having. And so that we can have a risk reducing surgery.
Yes.
That if it is an ovarian cancer, you can go for a risk reducing salpingolectomy, or if you can give a PARP inhibitors, medical tamoxifen or anything you can give. So medical management, also surgical risk reduction, surgical management can be offered to patient after completion of their family if patient is a mutation. So it is the message is that if no risk, nothing to be done. If there is a risk is there, then you can go for TVS and also for the CA125. But if there is a family history is there, then go for the genetic testing.
So screening for endometrial cancer. So coming to screening for endometrial cancer, usually there is no protocol for endometrial cancer screening method. And we are usually when only thing we see is the endometrial thickness. So in transvaginal ultrasound, if its cutoff is 4 millimeter, if less than 4 millimeter the endometrial thickness, we may follow up for after 3 to 5 years. If it is endometrial thickness is higher than 4 millimeter, you have to give do a biopsy. The 3 types of biopsy we do is the endometrial people biopsy. So people biopsy is most simpler and office procedure. You can do not have anything to do, thus just collects with the pipette. So people biopsy. Second thing is the DNC and endometrial biopsy. The age-old procedure can be done. Or third thing is the with the hysteroscopy directed endometrial biopsy, which is more gold standard for postmenopausal bleeding and all that. So it is unless if it is indicated, so you are not going for the these things with the invasive procedures. Otherwise, we can go for the endometrial thickness measurement regularly at a 3 to 5 years interval for screening. And if it is sometimes we see that the endometrial thickness is 11, 12 mm we see, but this is should not be hurry that it is a endometrial cancer. But sometimes endometrial polyp may give rise to this type of features. So which should be managed. Which should be managed by the 3D, 4D images of the ultrasound. So how to do people biopsy? How do you do people biopsy? Anybody? A people biopsy is a simple procedure, just a pipette-like thing. You enter into the cavity, just rotate 360 degree 2 to 3 times, and there will be sample will be collected and take it for examination. Or office hysteroscopy. What is office hysteroscopy? Office hysteroscopy is a method, is a simple method without anesthesia. You can go enter into the endometrial cavity and see the whether there is any lesion.
If there is active bleeding, you don't want to do hysteroscopy.
No, we are not going for bleeding. This is only the screening. When you are going,
the case that you showed was she was bleeding.
That is afterwards. I am coming to that. I have not yet come. then you can go office in the bleeding also you can do office hysteroscopy. There is no contraindication. So office hysteroscopy you can do without anesthesia. But if you are not able to go through the people biopsy or introduce the cannula, or your office by hysteroscopy you are not able to do, you can do under GA hysteroscopy, direct hysteroscopy under general anesthesia, and take the sample from the this endometrial cavity for histopathology. So histopathology is, if it is endometrial cancer, you has a definitive treatment like EHBSO or something. So when there is a
due to short of time, we will go for the case 3. Actually, this case I have put it, they have given the scenario, but this is my own case. My my sister-in-law died of cancer due to 42 years. At that time, her daughter was studying at JIPMER, undergraduate student. So this case scenario is Miss Epi. She is a 24-year medical UG student, lost her mother due to breast cancer. Her maternal aunt also suffered from breast cancer and treated both surgically, and she survived, but her mother died. How to evaluate her and counsel her? She is the daughter of my brother.
She is a high suspect of hereditary breast and ovarian syndrome.
Be near the mic.
Won't get this is the real case scenario. She is daughter of my brother. I lost my sister-in-law due to breast cancer at the age of 44. She is 1 year junior to me. And really how to evaluate and counsel her?
So actually, the index case should have been evaluated. So whether the BRCA was done for your sister-in-law, that is the basic.
Yes, done. She was BRCA negative.
BRCA negative. So 95% of cases arise de novo. But still, there is an association. If your family has the cancer, you definitely are at a higher risk, and you should start your mammography, clinical breast examination, or at least ultrasound of the breast every 3 years, starting age of 30 years.
Yes, actually, if there is a no BRCA, there is a 1 in 10 risk. If it is BRCA1 positive, there is a risk of 6 in 10 cases. But apart from BRCA, there are so many other mutations are there, and which usually do not test during genetic testing, and that also causes breast cancer. Suppose you are testing for only BRCA, and then you see that yes, there is no genetic test. We cannot say like that. There are so many tests. So first is then a pedigree analysis and risk stratification should be done, and should be, since is a BRCA, known BRCA mutation in the family, how we are going to
nowadays BRCA is one of the genes which is responsible for this hereditary breast and ovarian cancer. That there are many more disorders. So nowadays we have whole genome sequencing or multi-genome NGS testings are available commercially. For that we just need simple blood sample, and they do at least testing for 50-60 known genetic mutations which are associated with breast and ovarian cancer, and the result is available generally within 2 to 3 weeks. So sometimes it also happens maybe when it was done. So that time, every time we are increasing and having better and better sensitivity with the tests. So even if it was negative at that time, it is still worth doing testing for her again with the whole genome sequencing or multi-gene NGS testing. If it is still negative, then might be she has not inherited that particular disorder, but still it is worth doing standard screening procedure for her.
Actually, the standard genetic single gel testing, but the future is that next genetic NGS sequencing and multiplex genetic sequences should be offered to a woman who had a family history of breast cancer if it is BRCA negative. If suppose this test report comes to positive, BRCA positive, what are you going to how to screen? If you do a screen test for the daughter and she came to be BRCA positive, how you are going to screen her?
So
She is only 24 years.
So we have to put her on screening earlier. We have to get her sonography.
You have to put her on increased surveillance. How we are going to do?
So we can do sonography every year. And
how frequently you are going to do?
Every year we can do.
You will do sonography. Is there any role of MRI?
MRI
As
also
you
has.
sir has discussed,
Yes,
MRI
when
has no role till 40 years. If we start MRI, we started between around 25 to 35 year, and mammogram we can start it at 30 years.
30 years. As the density increases.
So this is the guideline, NCCN guideline, American Society Cancer Guideline. If it is a high risk, then clinical breast examination for, madam, you can read out. What is the, she is a high risk, she is BRCA positive,
That means self-breast examination start at 18.
18.
Clinical breast every 6 months.
Every
from
6
age
months. Normally for
25.
annually, it is 6 months.
Mammogram and breast MRI annually after 25. And then once childbearing is complete, she can have risk-reducing salpingo-oophorectomy.
Also, they are at risk of ovarian cancer.
Transvaginal ultrasound, CA 125. There can be risk-reducing mastectomy. Angelina Jolie was very famous for doing it. Chemo prevention can be done by tamoxifen, raloxifene, aromatase inhibitors.
So,
The basic thing is be alert and go for a regular checkup.
that is the, she is under increased surveillance. That you should put her in increased surveillance. If she is BRCA negative.
We'll have to sum up. Our time is up.
Yes, time is up. So time is up.
Just I want to say, the patient age is 24 and she is BRCA positive. So most important thing to counsel her, get married and complete your family as early as possible. Because ultimately you have to do a prophylactic salpingo-oophorectomy, bilateral skin sparing mastectomy and reconstruction at the same time. This is the only thing which can prevent, because the chances of getting breast cancer in BRCA positive is almost to the extent of 40 to 80%, and ovarian cancer is almost to the extent of 40%. So ultimately, whatever you do, you can say we can do a chemo prevention, or we can put her on an increased surveillance, but still we have to do a prophylactic surgery in these cases. And these are the cases which we say we are doing surgeries to prevent the cancer. And one thing that we should keep in mind, that BRCA doesn't expose the patient to only for breast and ovarian cancer. There is a list of 11 to 15 cancer to which the patient is now at an increased risk. So she has to be on increased surveillance. She has to undergo endoscopy. She has to undergo even multiple sonography to see whether she is not susceptible for cholangiocarcinomas, for stomach cancer, for colon cancer. So that spectrum is totally different.
Yes. Suppose she is any positive comes out, you should do. Thank you for. Thank you.
Sum up.
Yes.
We have come to the end of the session, and thank you the panelists. But key message is that regular screening, prophylactic vaccinations, and keeping your health at the low body weight, maintain the body weight, healthy lifestyle, etc., will prevent you from the cancer. And regular checking will detect the early stage of the cancer, and we can prevent the mortality and morbidity due to cancer. Thank you all. I thank also my expert here. They have their opinion while giving the panel in the panel. So thank you all again.
Thank you, sir. Thank you, ma'am.
Mobile.